Welcome to the McTox Curriculum, brought to you in collaboration with Western University, the University of British Columbia, and McMaster University. This presentation is part of the McTox Curriculum created for residents and fellows from PGY 1 to 5. This module is about lithium toxicity and is brought to you by Bandar Ba. By the end of this 10 minutes, learners should be able to discuss the different types of lithium toxicity and have developed an approach to the lithium toxic patient. They should be able to explain the concepts of treating lithium toxicity by discussing different treatment options available and outlining the different indications for hemodialysis. I'll be presenting 3 cases, and I would like you to pay special attention to the type of lithium toxicity, the signs and symptoms, and lithium levels so that we can discuss the approach and management, including any decontamination that's needed. The first case is a 79-year-old female who presents with a 1-day history of confusion and altered level of consciousness. This is on the background of a few days of loose stools and generally feeling unwell. Her past medical history is significant for depression and high blood pressure, and the medications she is taking include lithium, ASA, Lasix, and lisinopril. On physical exam, you find an elderly lady with slight tachycardia and a borderline blood pressure and oxygen saturations. She is agitated, moving all 4 limbs, and looks mildly dry. You appropriately order blood work for this patient. Her lab work reveals normal electrolytes, a mildly elevated WBC, a high creatinine at 288, and a VBG with a pH of 7.31, PCO2 of 32, and a bicarb of 20. Her lithium level comes back at 2.7. Important questions for you to think about in this case are what type of lithium toxicity is present, how would you approach it, do we need to decontaminate the patient, and what would your overall management plan be? Case number 2 has a 21-year-old male who presents approximately 2 hours after taking a lithium overdose of 20 300 milligram tablets. He is otherwise healthy and on no medications. His vitals are all within normal limits, and his physical exam is unremarkable. After sending off your typical tox blood work, it all comes back unremarkable except for an elevated lithium level of 5.2. You ask yourself the same questions as the first case. What type of lithium toxicity is this? How will you approach it? Do we need to decontaminate? And what will your overall management plan be? In our final case, we have a 44-year-old female who also presents 2 hours after ingesting a lithium overdose of 20 300 milligram tablets. She does have a positive history of bipolar disorder and epilepsy and is taking lithium and dilantin. She is mildly tachycardic with a heart rate of 110. In the ED, she had a 2-minute seizure, but now only has a tremor and mild agitation when you examine her. The patient's blood work shows normal electrolytes, CBC, and renal function. Her VBG has a pH of 7.32, a PCO2 of 34, and a bicarb of 21. Her lithium level is 3.1. Going back to our questions, what type of lithium toxicity is this, and what will be your overall approach and management plan? Let's take a look at the following questions. What are the different types of lithium toxicity? Why are there different types? And why is it important to understand and differentiate between them? In the next few slides, we will be discussing the answers to these 3 questions. In order to appreciate the importance of the different types of lithium toxicity and to properly evaluate and treat the lithium toxic patient, we need to understand how the body deals with lithium. In particular, we care about how lithium is eliminated and reabsorbed in the kidneys. Despite being used in medicine for over 50 years, the exact mechanism of action of lithium is not fully understood. We do know, however, that the main site of action in the human body is the nervous system. When lithium molecules are circulating in the blood, it has almost no systemic effects. Since lithium has a low volume of distribution of 0.9 liters per kilogram, it circulates in the intravascular compartment for some time before it redistributes into other compartments and tissues. It may take up to a full day to reach the brain, and only then will symptoms start to appear. A patient who is taking lithium on a regular basis already has lithium molecules acting in their brain. That means that they have been saturated, or that their body burden of lithium is high. In these patients, it does not take a large amount of extra lithium or extra time to show neurotoxicity in an overdose. Based on the body burden, lithium toxicity is classified into 3 types: acute, chronic, and acute on chronic. Now let's talk about the relationship between lithium and the kidneys with regards to its elimination and reabsorption. Lithium is mainly eliminated by the kidneys, and this elimination depends on GFR. Any cause that decreases the GFR will lead to decreased lithium elimination. Kidneys see lithium as a sodium ion, and under normal physiologic conditions, the kidney reabsorbs sodium as needed to control fluid status in the body. In the case of dehydration or sodium depletion, the kidney reabsorbs more lithium thinking it's a sodium molecule. This will decrease the amount of lithium being eliminated and increase its level in the body. To increase kidney elimination, physicians should correct any dehydration and increase the GFR by giving IV fluids. Let's take a minute here and think about the role of diuretics in the treatment of lithium toxicity. Based on the information you've heard, would you recommend a diuretic therapy? Why or why not? Sometimes patients can't tolerate a large volume of IV fluid, or it might take too long to allow physiologic elimination of lithium from the body, which would allow the high levels of lithium time to exert neurotoxicity. Hemodialysis is a recommended treatment when there are neurosymptoms, the patient cannot tolerate IV fluids, the kidneys are not functioning well enough to eliminate it, or if the lithium level is simply too high for the kidneys to handle in a timely fashion. It's important to know the absolute cutoff levels to initiate dialysis. This is greater than 4 in an acute overdose, or greater than 2.5 milliequivalents per liter in a chronic overdose. Now let's go back to the cases and highlight the important points which help us delineate the management plan for each of these patients. In the first case, we had a 79-year-old female who was on lithium at baseline. She developed diarrhea, which made her dehydrated, and put her into a prerenal AKI. This gave her a chronic lithium toxicity with neurosymptoms. In this case, there is no role for decontamination. Instead, we should begin conservative treatment with IV fluids to correct her dehydration. She also meets criteria for hemodialysis based on her neurosymptoms and her lithium level. Our second case had a healthy 21-year-old man who had an acute overdose of lithium 2 hours ago. Because of his recent overdose, he was asymptomatic at the time of assessment, but his lithium level was 5.2. Given the severity and timing of this overdose, he would definitely benefit from whole bowel irrigation. He should also be started on the conservative treatment of IV fluids. Given his lithium level of 5.2, he should also receive hemodialysis and be admitted to hospital. For our last patient, she seemed to fit into an acute on chronic lithium overdose. She was clearly symptomatic with seizures, tremor, and agitation, and her lithium level was also elevated at 3.1. Given the acute component of her overdose, she would also benefit from whole bowel irrigation. We can also start her on IV fluids, which may be of some benefit, but she's primarily going to require hemodialysis to treat her lithium overdose. In summary, we know that lithium toxicity depends on the body burden of lithium molecules in the brain cells, and that clinical correlation is better than absolute lithium levels in the 3 different types of toxicity. We know that fluids and hemodialysis are the mainstays of treatment, and that there is no role for forced diuresis. The final questions for this module are 1. Out of the 3 cases, which patient would take priority on dialysis and why? 2. What would you do if your patient needed dialysis, but there was no dialysis machine at your institution? And 3. What are the available decontamination methods for your lithium overdose? Thanks for watching, everyone.